This is the last abstract for this session. It's entitled High Incidence of Type 2 Endoleak and Low Associated Adverse Events in the VQI linked to Medicare claims. This is presented by Dr. Mansukhani on behalf of co-investigators at the Medical College of Wisconsin, Weill Cornell Medical College, Dartmouth Hitchcock Medical Center, and Northwestern University.
Thank you for the introduction, and thank you for the opportunity to present our work here today. We have no relevant disclosures. Type 2 endoleak is the most common finding on postoperative surveillance imaging after EVAR and is associated with a low rate of aneurysm-related mortality. This has been shown in multiple single-center and administrative data sets. However, the natural history, optimal management strategy, particularly if and when to perform re-imaging, re-intervention, and the efficacy of re-intervention remains controversial. The purpose of our study was to evaluate type 2 endoleaks and their natural history using the VQI database linked to Medicare claims. This valuable resource augments the VQI by providing further insight into Medicare patients' long-term follow-up by capturing rates of imaging, re-intervention, mortality, and other metrics. This decreases the VQI database's limitations on long-term follow-up for some outcomes. This was a retrospective review of the Medicare-linked VQI database of EVAR procedures performed from 2015 to 2017. Excluded were any patients with non-type 2 endoleaks and patients without type 2 endoleak on completion angiogram without subsequent imaging follow-up. The exposure variable was type 2 endoleak on EVAR completion angiogram or type 2 endoleak detected on surveillance imaging at any time within the first postoperative year. Standard statistical methods were applied. The study period was limited because 2015 is when the endoleak variables were expanded in the VQI, and Medicare follow-up was available through 2018. We examined all included patients for postoperative mortality, all-cause re-intervention, type 2 specific re-intervention, and frequency of postoperative imaging. We also specifically examined patients with type 2 endoleak for rates of spontaneous resolution, aneurysm sac regression, and type 2 endoleak resolution after re-intervention. Finally, we explored the association of prophylactic branch vessel embolization with type 2 endoleak, specifically the association with endoleak frequency, resolution, and aneurysm sac regression. 34,000 patients were considered for inclusion as captured by the Medicare-linked VQI EVAR module. After limiting inclusion to patients' first procedure during the 2015 to 2017 period, the population was limited to around 14,000 patients. After excluding patients with any other type of endoleak, without Medicare enrollment, without complete one-year Medicare follow-up, and without complete imaging follow-up, the study population was limited to about 5,500 patients that had granular patient, procedure, and imaging data with claims-based follow-up. About 1,300 or 25% of these patients had a type 2 endoleak, and about 4,100 or 75% of patients did not have a type 2 endoleak. There were negligible differences in demographics such as sex, race, comorbid conditions, antiplatelet and anticoagulant use, functional status, and prior aortic surgery between the two groups. Advanced age and non-smoking status was associated with type 2 endoleak, and 91 patients underwent prophylactic branch vessel embolization. For 2.5 years postoperatively on univariate analysis, there were no differences in overall re-intervention rate, in rate of re-intervention for type 2 endoleak, or mortality. Next, we examined all patients with type 2 endoleak and long-term follow-up by culprit vessel. After the first postoperative year, median follow-up was 402 days, and this was 2.1 years post-index procedure, since we allowed 1 year post-procedure to detect an endoleak. Spontaneous resolution occurred in 73% of patients during the follow-up time at a median of 398 days after the first postoperative year. There were no differences in delays to spontaneous resolution based on culprit vessel. IMA-based endoleak had an average decrease in sac diameter of 1 millimeter versus 4 millimeters and 1.5 millimeters for accessory renal and lumbar-based endoleaks. IMA-based endoleaks also had the lowest rate of spontaneous resolution at 60% compared to 77 and 79%, and had the highest rate of aneurysm growth prompting reintervention at 4 millimeters compared to 1 or 0 millimeters for lumbar and accessory renal-based endoleaks. Of the 26 patients with type 2 endoleak who underwent reintervention, 20 patients, or 76%, had evidence of endoleak resolution. Next, we examined the 84 patients who underwent prophylactic branch vessel embolization with and without evidence of postoperative type 2 endoleak, compared to patients with type 2 endoleak who did not undergo prophylactic branch vessel embolization. Of the prophylactic branch vessel embolization patients, 68 or 81% did not have a detected type 2 endoleak, and only 16 or 19% had a detected type 2 endoleak. Patients without detected type 2 endoleak after EVAR with prophylactic embolization had the smallest aneurysm diameter and greatest rate of aneurysm sac regression at follow-up, with a median diameter of 47 millimeters and a difference of negative 7 millimeters in maximum diameter compared to the baseline. No patients who underwent prophylactic branch embolization with a detected type 2 endoleak postoperatively required any reintervention. Finally, multivariable regression analysis was performed adjusting for all demographic, comorbid, and procedure-related factors. This showed that type 2 endoleak was not associated with an increased risk of mortality, reintervention, type 2 endoleak-specific reintervention, or rate of follow-up imaging. In summary, type 2 endoleaks have high rates of spontaneous resolution within the first 2 years of EVAR, are associated with low rates of aneurysm sac growth, and have no evidence of early associated mortality. Also, prophylactic branch vessel embolization is associated with aneurysm sac regression and low rates of intervention. In conclusion, type 2 endoleak is generally benign within the first 3 years after EVAR. We suggest only highly selective early reintervention and reimaging for type 2 endoleak after EVAR, and suggest that prophylactic IMA embolization may be indicated in some circumstances. Thanks to my partners and collaborators for your support, and the VQI Vision Analytic team for making this possible. Happy to take any questions.
All right, any questions from the audience? And if not, I believe you're off the hook since we're over time. But thank you for your, we have one question. Go ahead.
David Chu from Des Moines, Iowa. I happen to be in the group that believes strongly in prophylactic branch embolization. And and you hear in our presentation tomorrow, I think it took us about 3 years of follow-up to see sac growth from type 2 endoleak. So this is 2-year follow-up. I don't think it's long enough. At 3 years, we saw it, and the median growth rate was 7 millimeters increase in sac size.
Thank you for your comment. I agree with you. I'm also a proponent for prophylactic embolization, and the limitation in the study follow-up period was mostly limited by availability of linked Medicare data. So I'm looking forward to doing a follow-up study after this one with another 4 to 5 years of follow-up data. So thank you for that comment.